A very good evening and warm welcome to all the dignitaries present here. I am Momita from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the General Practitioners Association Kerala, and the focus of today's session is blood transfusion. It's essential insights for general practitioners. So, without any much delay, let's begin today's session, for which I would like to invite Dr. Azhar Nazar, sir, to take over further. Over to you, sir.
Hi, good evening, everyone. I'm Dr. Ansar Nasser from GPA Academic Wing, and I'm delighted to welcome you all to this webinar on transfusion medicine. Uh, Although the blood bank and blood transfusion have been a crucial component of healthcare for many years, transfusion medicine as a separate postgraduate branch was introduced very recently in the Indian medical education. And that makes this today's session more exciting. I'm supposed to be giving an introduction to blood transfusion and transfusion medicine, but since we'll be dealing with them in great detail in the main session, I'm not planning to prolong this talk. In today's session, we'll be dealing with both blood transfusion in the context of general practice and also with transfusion medicine as a branch for specialization. And for that, we have a wonderful faculty with us, Dr. Arun Vijay, MD Transfusion Medicine from the Department of Transfusion Medicine, MMC Hospital and Research Center. He's also the editor of Transfusion Medicine Academic Society newsletter, and he's also a working party of the International Society of Blood Transfusion and a member of International Outreach Committee. So without further ado, I would like to welcome Dr. Arun Vijay for the main session. Over to you, sir.
Good evening, everyone. I hope I am audible.
Yes, sir, you are audible. Yes, you can go.
Is my screen visible?
Yes, perfect.
Okay, so I thank GPA for giving this opportunity. So I completed my MD transfusion from Thrissur Jubilee Mission Medical College, and I have worked at MVR Cancer Center. And currently, now I'm working at MMC Medical College Hospital and Research Center in the Department of Transfusion Medicine. We'll go through the essentials of blood transfusion for a general practice point of view. So this is the overall outlay of my presentation. We'll go through anemia and alternatives to transfusion in very brief. Then I'll give an introduction to the blood centers, how it functions, then the different blood components which are available, then the different transfusion thresholds for different diseases and for different components, and what to note during the transfusion from a general practice point of view, and how to manage a transfusion reaction. So the appropriate use of blood and blood product means that the transfusion of safe blood only to treat a condition leading to significant morbidity and mortality that cannot be prevented or managed effectively by any other means. That means that transfusion is a last resort. You have to rule out other conditions and anything other that can be treated otherwise. And lastly, you come to blood transfusion. That is because blood transfusion in itself has some kind of adverse reactions, and there is a risk for every transfusion. So we have to weigh the benefit versus the adverse events and give the order for a transfusion. So when we think about the alternatives to transfusion, first of all, when a patient with anemia or any other bleeding disorder comes, you have to screen for the anemia and coagulopathy and try to diagnose what type of anemia it is. The diagnosis and management of anemia of elective cases can be taken up. That means that for if you're working in a general practice or a general surgeon, a patient for a routine surgery like hernia comes to you, and you post the case for 1 month. After 1 month, you have ample time to give them some other means other than a blood transfusion to raise their hemoglobin and take up the patient for surgery later. You have oral or parenteral ions to give them. You can give them colloids or crystalloids in case of any conditions. So hemoglobin levels to diagnose anemia. This is the given by the WHO. So the first table gives you the cutoff for anemia. So as you can see, the cutoff for anemia in men is less than 13, and for non-pregnant women, 15 years of age and above is less than 12. So with this criteria, the WHO has done a study, and they have found out that, as you can see in the second table, comes in the middle, the proportion of population with anemia, hemoglobin less than 11 gram per deciliter is 74.73. That means that it's a severe public health condition. More than 50% of our population in India is anemic. And one of the reasons is that if we check more than 50% of females is anemic, on our routine examination, we see the hemoglobin as 10, 10.5, 11. So we are so accustomed to the anemia that we think that anemia is normal. A hemoglobin of 11 or 10.5 is considered as normal among general practitioners. We have to change our outlook on anemia and see that even a hemoglobin of 11 is not sufficient. We have to strive to improve the anemia or hemoglobin of our patients. And general practitioners is the best place to start and the best way to tackle the pandemic of anemia. So now, when the patient presents with anemia, you will do a hemogram or a CBC. In that, there will be absolute reticulocyte count. So if the reticulocyte count is low or normal, it can be due to decreased or ineffective RBC production. Then you look at the mean corpuscular volume, the size of the RBC. And if the volume is low, it is microcytic. It can be due to iron deficiency anemia or anemia of chronic inflammation. If it's normal, there is a differential diagnosis of a plastic anemia or something like that. If there is high, the size of the RBC is very big, the mean corpuscular volume of the RBC is high, it can be due to vitamin B12 like megaloblastic anemia, folate deficiency, things like that. So if it's an iron deficiency, which is the most common anemia prevalent here, we can see that it's microcytic hypochromic anemia because of the low MCV, small volume RBCs. Now, again, when an anemia presents and the reticulocyte count is high, it can be due to RBC, excessive RBC loss. It can be due to acute hemorrhage or hemolysis due to various causes. So we would have studied different classification, different treatment protocols and everything for this. So I'm just going to skip it. I'm just giving a broad outline. So the first of all, for the treatment of anemia, it's the dietary modification. You don't prescribe iron tablets outright. You can go for an dietary modification in these patients. You can give chickpea, mustard leaves, fenugreek leaves, things like that. Basically, all green leafy vegetables you can give for anemia because they are iron rich. Other iron rich food includes red meat, like beef, pork, things like that. Then fruits like watermelon or pomegranate, dates, dry fruits like dates, they all contain high amount of iron. Even the ragi, it's commonly available, and ragi can be mixed with the dosha batter for idli, doshas, and for all these things we can use ragi. So the thing is to introduce this kind of iron-rich food in our daily diet, just for not for 1 day or 1 week or 1 month. It has to be incorporated into our dietary habits in the long run for months. Then we can see the slow increase of hemoglobin in our patient's blood. So we can go for oral iron therapy. So there are different iron preparations available like ferrous gluconate, ferrous sulfate, ferrous fumarate, things like that. So the thing to note is that the traditional teaching is to give 100 to 200 milligram elemental iron in divided dose per day. So as you can see in this chart, different preparations has different amount of elemental iron. So what you have to notice, whichever tablet is available with you, you just look at the elemental iron in that tablet and ensure that the patient receives 100 to 200 milligram of elemental iron in divided doses in 1 day. So each clinic or each hospital setting will have different iron preparations. If you're sticking to one, it's very easy. So just look at the elemental iron content in the tablet and prescribe accordingly. And one of the most common adverse effect or side effect is gastrointestinal intolerability, unabsorbed iron, and irritation to mucosa. So advise the patient that there can be a chance of gastric irritation. You can give them medications for that, or you can try different companies. I'm not going to name any particular company because we don't want to promote anything. But some iron tablets have high incidence of gastric irritation. At the same time, some companies are very good. So the patient will become more compliant to the iron therapy. Now, the initial introduction about the anemia and everything is over. Now, coming to the blood center part. So, we specialize in transfusion medicine. Transfusion medicine, the core is the blood banking. You call it as blood banking. The blood bank term is not at all used right now. We are going, the government has replaced the name blood banks with blood centers. So, it may be the reason that bank is somewhere where you deposit something and when you need it, you take it back. Blood centers are not like that. You donate for some patient you don't know, and it's a center where blood, it's a source of life, gets distributed to the patients, whoever needs it. There is no banking system there. So all activities related to the transfusion of a blood and blood components should be in accordance with the Drug and Cosmetic Act 1945. So whatever we follow the rules and regulations, everything is as per Drug and Cosmetic Act. If it's said in the act that you're not supposed to do this, or you're supposed to do cross match in this type of way, or you're supposed to give the blood in this type of way, you can only follow that rule. You're not supposed to change that rule. It's a strict guideline. So, like the first slide I presented, a blood transfusion has the potential to be hazardous, and hence a transfusion should only be given if the potential clinical benefits outweigh the potential risk to the patient. So, every transfusion has the potential to impact a patient in one or many ways. But the thing is that we don't see the effect in the short term. It may take years to develop a complication. Maybe if unfortunately the blood had an infection, transfusion transmitted infection like hepatitis or HIV, it may take years for the patient to develop any signs or symptoms, or even to diagnose. So the blood donation should be done only in a licensed blood center. If the hospital doesn't have a licensed blood center, you're not supposed to take up any blood donation activities in your hospital or center. The blood center license is renewed after inspection by the central drug controller for every 5 years. So the license is for 5 years. Every 5 years, the blood center has to go for inspection by the central government, and they will come and inspect and they will approve the license. Each blood component has to be licensed separately, and you have to ensure that the requirements for each of the component is met. Whether we are following the protocol, there has to be standard operating procedure, there has to be specific equipment to prepare specific blood components. Only if you have these components and the facilities to test the quality of these components, you will get the license. So this is one of the recent guidelines by the Ministry of Health and Family Welfare. It was released on 11th March 2020. It is the latest modification how the blood bank should function, which all blood components can be prepared, how it can be prepared, and the donation criteria for India. So please note that different countries has different rules. So if the government says something, we have to follow it. So the donation criteria for India and US or UK or Europe might be different. So actually the donation criteria is very long. It contains about 80 to 90 points, and the donor questionnaire is supposed to be 3 to 4 pages. I have just compressed it into just 24 points for the ease of understanding. I don't think many of you will be working in a blood center, but it's good to know that which all donors can donate, who are eligible or who are ineligible. So you have to be maximum 48 kilograms of weight, hemoglobin of minimum 12.5. Age is 18 to 60 years. If you are a repeat donor, you can go up to 65 years. You have to have good night's rest and sleep previously. You have to have a meal before donating the blood. And the donation interval for male is 3 months, while for females, it's 4 months. For tattooing and ear piercing, which is an unregulated procedure happening outside the hospital, there is a skin piercing. So it can carry an infection like HIV or hepatitis if the needle is not properly sterilized. So the deferral period is 12 months. You can donate only after 12 months of the procedure. For root canal or dental extraction procedures like that, you have to be deferred for a period of 6 months. On any kind of medications, different medications has different deferral period. The common ones are an antibiotic of 14 days. For antifungals, you cannot donate for 7 days. For painkillers, 3 days. You cannot donate for thyroid medication. And for diseases like cancer, asthma, cardiac and lung, liver, kidney diseases, permanent damage, you are not able to donate for lifelong. And for infections like HIV, hepatitis B, hepatitis C, which are known to be transmitted through blood. If you once you have a diagnosis of these diseases, you are not supposed to donate blood. For vaccinations like tetanus or COVID, you can donate after 14 days. For rabies vaccine, it's an immunoglobulin, so you have to wait for 1 year to donate. Any history of minor surgeries under local anesthesia, any stitch or suturing, something like that, you have to wait for 6 months. After that, you can donate. For major surgeries that require general anesthesia, you can donate only after 1 year. During pregnancy, you cannot donate blood, and 12 months after delivery. Females specifically, they cannot donate blood if they are menstruating or breastfeeding. And for abortion, you have to wait for 6 months post-abortion. If you have any type of infection symptoms, cold, fever, sore throat, cough, anything like that, it's better to avoid blood donation for a period of 14 days to ensure that there is no bacterial contamination in the donated blood. Any high-risk behavior like transgender, men who have sex with men, female sex worker, drug abusers, person with multiple sex partners, due to the high-risk behavior, you are not supposed to donate the blood. You have to declare that you belong to none of this criteria before donating blood. And the most common diseases include diabetes, hypertension, and cholesterol. So there is a lot of myths among population that you cannot donate blood if you're diabetic. But if you fulfill a few criteria, you can donate blood actually. They can donate blood if the control through diet or medicine, the sugar levels has to be controlled. No change in the medicine or dose in the last 4 weeks. No other complications like infection, neuropathy, vascular diseases for the patient due to diabetes. And you cannot donate if you're on insulin. If you fulfill all these 4 criteria, you're okay to donate. And for hypertension, similarly, your pressure has to be normal, systolic 100 to 140, diastolic 60 to 90. There has to be no end organ damage or complications for any of the organs. And the medicines or the dose has not been changed for the last 20 days. If you fulfill these criteria, even if you're hypertensive, you can donate blood. And for cholesterol, hypercholesterolemia, even if you have hypercholesterolemia, even if you are taking medicines for it also, you can donate blood because it doesn't affect the quality of the blood. And you can donate even if you are on vitamin supplements like vitamin B12, iron, folic acid, vitamin D. You can also donate blood. There are no issues for that vitamins. So coming to the different blood components, like I said in the last gazetted notification, the drug controller has said that we are able to prepare 26 different types of modified blood components. I have given just a list of few blood components. So the most common ones are PRBC is packed red blood cell corpuscle. Second one is leukoreduced PRBCs. Third one is irradiated PRBCs. Then it can be PRBC aliquot. We can, for pediatric or neonates, we can divide it into smaller bags and give it to them. There is saline washed RBCs. There is FFP, cryopore plasma. Random donor platelet is what you call as platelet concentrate, RDPs. Then it can be pooled. Then it can be leukoreduced random donor platelet washed. SDP is single donor platelet. So then there is PBSC, peripheral blood stem cells. Those are the stem cells we harvest from the bone marrow through the peripheral blood, and you use it for bone marrow transplantation or hematopoietic stem cell transplantation. Then there is apheresis procedures through which we can harvest any blood component. Like you can harvest only RBCs, you can harvest only WBCs. Within the WBC, you can harvest mononuclear cells, you can harvest lymphocytes alone, you can harvest granulocyte alone. So there are different apheresis components also, which are not available in all the centers, but available in few selected centers. So the most common components available in majority of the centers are PRBC, FFP, platelet, and cryoprecipitate. So we'll concentrate on these ones. So this table includes the volume, the temperature, dose, and the expected increment, and the transfusion duration for different components. So for PRBCs, the volume will be around 280 ml. That depends on the type of the bag and things like that. It is stored at 2 to 6 degrees Celsius. The dosage is 10 to 15 ml per kilogram of the patient weight. So ideally, for 1 unit transfusion, we expect a 1 gram increment in the hemoglobin. And you have to complete the transfusion within 4 hours. For an FFP, the volume is around 200 ml. It has to be frozen at minus 18. So it will be frozen at, it's solid frozen at minus 18. The dosage is 10 to 15 ml per kilogram. It will give a 20% rise in the factor levels of FFP. 1 unit can be transfused over 20 to 30 minutes. For platelet concentrate or random donor platelets, the volume is around 50 ml. The storage temperature is what is called as room temperature as 20 to 24 degrees Celsius. 1 unit of RDP, we are expected to give an increment of 5,000 to 10,000 unit of platelet in the patient. So that means that suppose the patient has 10,000 units of 10,000 platelet count, and you want to increase the platelet count to 50,000. For that, you need a 40,000 increment. So you need at least 4 to 6 units of platelets to get an increment to 50,000. So 1 unit random platelet, it gives only 5,000 to 10,000 platelet per microliter in the patient. It's a small volume, so it can be transfused within 30 to 60 minutes. Then there are apheresis components and cryoprecipitate. Now, coming to the PRBCs, there are different thresholds to initiate a transfusion. So there are different guidelines for different countries according to their study population. This I have taken from the Kerala State Transfusion Policy. We have a policy called like that. So they have given, after literature review, they have given a cutoff for us. We can follow it. So the anemia in stable non-bleeding patient. So the patient is just anemic due to some nutritional deficiency, maybe iron deficiency. The patient doesn't have any other organ damage, and the patient is not bleeding and hemodynamically stable. So you can wait till 7 to 8 grams to start a transfusion. You need not transfuse for a 9 gram hemoglobin. You need not start a transfusion. 1 unit PRBC is not needed actually. For chronic kidney disease also, you can wait to, the criteria is different for different guidelines. So you can wait to 7 to 8 grams. Then for, if you have a pre-existing coronary heart disease, then the cutoff is a little high. You go to 8 grams. You have to keep the hemoglobin above 8 grams at all time. For acute coronary syndromes, if it's acute, you have to keep the cutoff a little bit higher again, ideally around 10 to avoid any further incidents. Then for critically ill, 7, for different criteria like that. Then for congenital heart disease and cyanotic heart disease also, we have a higher cutoff of 9 gram per deciliter. So according to this chart, it's available to be downloaded. So it's called as Kerala State Transfusion Policy. You can look it up, or a different policy. You just have to follow some authentic transfusion guideline. Now I mentioned about different modified blood products. So one of them is leukoreduced PRBC. So there is a separate filtered bag for leukoreduction. If you pass the PRBC through that filter, the WBC will be removed. Please note that doesn't guarantee 100% removal, but there will be significant removal. And the significance is that the WBCs have leukocytes have, it can cause antibody development within the recipient or the patient. So leukoreduced PRBC is not routinely indicated. If you are an affordable patient, you can give it to everyone. But the thing is that since leukoreduced PRBC, the filter itself is very costly. So you have to ensure that you choose the patient wisely. So these are the indications. Patients with recurrent FNHTR or febrile non-hemolytic transfusion reaction. FNHTR means that the patient gets fever every time you transfuse a blood component. So one of the reasons might be the WBCs and the cytokines released by the WBCs. So you use a leukoreduced PRBC with a filter and remove the RBCs, and so cytokines will not be released and the patient will not have fever post-transfusion. So it has to be recurrent. Next one is to prevent the cytomegalovirus infection. Another point is that more than 90% of the Indian population is cytomegalovirus already positive. So that's not a proper indication for India, but it's international standard. Then for pregnant women, it is ideal that we give a leukoreduced PRBC. Then for patient requiring prolonged transfusion support, leukoreduced PRBC is advised. So for thalassemia and sickle cell disease, when the patient may require repeat transfusion, it is ideal to give a leukoreduced PRBC, so there is less sensitization and less development of antibodies in the patient. Then the candidates for hematopoietic stem cell transplant. For the transplant patients, definitely you have to give leukoreduced and irradiated PRBCs. And the candidates for solid organ transplant, you have to give leukoreduced PRBC, intrauterine transfusion, and the premature babies and neonates. Now for irradiated PRBC, for the purpose of irradiation is to damage the nucleus of the WBCs, so it became inactive. So leukoreduction removes majority of the WBCs, and if you irradiate that one, you get 100% inactive WBCs within the any blood component. So it is indicated in immunocompromised patients like intrauterine transfusion, premature infants, neonatal exchange transfusion, congenital immunodeficiencies, and bone marrow transplant patients, and for granulocyte infusions. Now, coming to the platelet threshold, prophylactic transfusion in patients with no risk factor of bleeding is 10,000. So you need not transfuse if the platelet count, you can wait up to 10,000 count per microliter. But in a practical point of view, if you're working in a hospital with good blood center and ready supply of platelets, you can wait till 10,000. But if you are in a periphery and you don't have a blood center, it's not easy to get access to a platelet concentrate, then it's up to you to either refer the patient or keep a higher cutoff. Now, patient with coagulopathy of heparin, 20,000 is a cutoff. Bleeding out, but not severe or life-threatening, 30,000. If it's severe bleeding, like massive transfusion, you have to keep a cutoff of 50,000. For major surgeries, minimum cutoff of 50,000. Neurosurgery or microvascular surgeries, 1 lakh count. Cataract, there's no prophylaxis. And for different lumbar puncture, you have 50,000. Spinal anesthesia, 50,000. Things like that. Now, for fresh frozen plasma, these are the indication: temporary warfarin reversal, liver disease with protein synthetic defect, prevention and treatment of dilutional coagulopathy, correction of deranged coagulation parameters, specific coagulation factor deficiency, consumptive coagulation with bleeding, to counteract the effect of fibrinolytics, some rare specific plasma protein deficiencies, to treat excessive intraoperative microvascular bleeding. Now, all these are the indication. Now, I want to stress on the conditions where plasma is not indicated, and that is volume expansion, correction of hypoalbuminemia or hypoproteinemia, replacement of parenteral nutrition, enhancement of wound healing. The thing is that we have albumin as a substitute, but majority of the clinicians do not use albumin because of the cost. So they try to use FFP for correcting the hypoalbuminemia. And FFP has no role in the replacement of parenteral nutrition. So please do not give FFP for parenteral nutrition, and there is no role of FFP in wound healing. Now, once we have introduced the components, what all things to be noted when you're transfusing at your center? So the treating doctor is the one responsible. So informed consent has to be taken from the patient or the next of kin. The patient is not conscious or something like that. You have to inform about the alternatives of transfusion, and you have to explain it in an understandable language. Now, the request, most of the hospitals will have a request form. Otherwise, you need to have a request form, or you have to fill all the details in your handwriting on a request form. So patient details, diagnosis, everything should be there. Definitely blood group should be in there. The component name which you require. If it has to be leukoreduced, you have to mention leukoreduced or irradiated. You have to write the indication. You have to sign the doctor's signature with the medical registration number and the seal, and the time of the requirement of the blood component. When you're sending a sample to a blood bank, to your blood bank or to another outside blood bank, always send EDTA sample and a plain vacutainer. EDTA is required for the grouping. We have to ensure that the what group you write is correct. So we have to receive a EDTA sample and a plain vacutainer, which is a red tube, red top tube for cross match. And you have to identify the patient with 2 identifiers. Please don't use just single name. Use name of the patient and UHID. Often there will be 2 patients with the same name in the hospital, and many of the times we have seen it's a real life scenario where the blood get mixed up or the patient get mixed up, and there is a chance for wrong blood in the tube, and it can cause hemolytic transfusion reaction, which will lead to organ failure or death of the patient. So always to identifier, label properly. Now, some of the queries I receive is when can you return the blood? Maybe for some reason you are not able to start the transfusion, you have to return the PRVC within 30 minutes. Please do not store the blood in the ward fridge. There are specifically designed, designated specific blood bag refrigerators within the blood bank. You are allowed only to store in that blood bank refrigerators. The ward fridge is not for the bag, and it will cause damage. If it goes out of the temperature or goes too cold, it can cause hemolysis in the bag. The treating doctor shall document the indication and outcome of the transfusion. If you return the bag within 30 minutes of the issue time, we will take it back into the inventory depending on the blood center. Otherwise, you have to transfuse it or discard it. You have to verify all the details of the patient and the bag, double check it, make sure there is no clerical error, check the blood center report, label, cross match and the patient record, duly sign the doctor signature on the medical records. you have to inspect the blood bag. You have to look for discoloration, clot, precipitate, or patency, or the leaks. You have to use two independent verifier to identify the patient and the bag. Mix thoroughly. So if you keep PRVC for some time, the red cells might get sedimented at the bottom, and the anticoagulant or the addictive solution might be on the top. So just mix it thoroughly and gently, and you can transfuse it to the patient. You always have to use a blood transfusion set with the filter. That is mandatory. The same set can be used for more than one unit for up to 4 hours, but you cannot give multiple components through the same line. That means that you cannot transfuse FFP platelet, cryoprecipitate, and everything should through the same line. For a PRBC, you keep one filter and transfuse it continuously up to 4 hours. After that, change the filter. Blood warmer is not mandatory, but if you want to warm the blood, only use specific blood warmer designed for that purpose. Do not warm it in hot water. It will cause hemolysis. Now, PRBC transfusion should be completed within 4 hours. Whatever you do, I have seen transfusions completing within 6 hours and 8 hours. So the temperature is to be kept within 2 to 8 degrees Celsius. You have to finish the transfusion within 4 hours of starting the transfusion, and start the transfusion immediately after issue. Now, no other medication is supposed to go along with the blood unit in the filter line or to the IV line. Only ones allowed are normal saline, albumin, or plasma products. No other medicine or anything, ionotropic drugs, nothing should be given along with the blood, or it should not be mixed with the blood bag. It should not be given through the same line. The patient has to be constantly monitored by the nurse or whoever is there who is in charge. The vitals need to be assessed prior to the transfusion for baseline, every 15 minutes for the first hour, then hourly till the transfusion is completed, and 30 minutes or 1 hour after the transfusion is completed, you have to monitor the vitals. So the speed of the transfusion, initial for the first 15 minutes, you have to start the transfusion slow. So PRBC 1 to 2 ml per minute, then increase the speed to 2 to 4 ml per minute, and should not exceed 4 hours. For RDP, 2 to 5 ml per minute, you start the transfusion. And once the 15 minutes over, you can increase the speed to 300 ml per hour. You can give 1 RDP or 20 minutes. For FFP, 2 to 5 ml per minute started. Then increase the speed to 5 to 8 ml per minute, and 1 FFP over 20 to 60 minutes. So at the end of the transfusion, you should have this much information in the patient's record: informed consent, indication of the transfusion, signature, pre-transfusion checks, signature of the nurse, type of the and volume of the unit, blood bag number, ABO grouping, time of start and end of transfusion, monitoring of the patients, transfusion reactions, if any. So there are different transfusion reactions, like I told, febrile non-hemolytic transfusion reaction, allergic reactions. Then it can be transfusion-associated lung injury like TRALI or TACO, transfusion-associated. There are different transfusion reactions. So you have to observe and monitor for this reaction. All events during a transfusion should be reported to the blood center. So if a transfusion reaction happens, stop the transfusion immediately, disconnect the set, inform the treating physician if you are a nurse. The blood bag, the set, the sample collected from the opposite arm has to be sent to the blood center. We'll take this entire blood set and blood bag and everything, and we'll do a workup on the transfusion reaction. And we assign a diagnosis to this transfusion reaction, like it's an allergic reaction. Maybe it's a transfusion circulatory overload. We'll study the patient's case file and you assign a diagnosis. You have to send a fresh urine sample. It is for assessing the hemoglobinuria to see if there is hemolytic transfusion reaction. Fill the transfusion reaction form, transfusion monitoring form, maintain IV access, and start normal saline. If it is a severe reaction, the patient will go into shock. So you need to have an IV access open and start a normal saline to save the patient. HTC is Hospital Transfusion Committee. Each blood center attached to hospital will have a transfusion committee. They will meet within a specified time period. So once in every 4 months or 6 months. And the team will include the blood center staff, the doctors, and the clinicians, head of the departments, and the medical superintendent who is there. And we'll discuss everything related to the blood bank, including this transfusion reaction. We'll finalize on it, and we report to a program called Hemovigilance Program of India, HPPI. And it's a centralized by the central government. So they will analyze it and give their findings once in a few years about what is the type of reaction, why it's happening, and they'll give it their opinion on that. As a coming to the end of my presentation, so I wanted to remind you that you can give across group transfusion. This is a table for the across group transfusion. It's available in the Kerala State Transfusion Policy, or it's available in the Google. So, for example, let me tell you why it's important. Because suppose there is an RTA, the patient is losing blood. The patient's blood group is AB negative, and for an emergency, AB negative is very difficult to find. You need 4 or 5 units. It's not easy to find AB negative 4 units or 5 units. If you can see this chart, the top box is PRBCs. For AB is a universal recipient. We have studied this in MCQ during our MBBS years. AB is a universal recipient. They can receive from AB, A, B, and O. At the same time, O is a universal donor. You can give to any group. So if O is available, it can be given to A, B, or whichever group, it doesn't matter. It depends on the blood group. It depends on the Karl Landstein's blood group. So just go through it and read this table. Keep it with you in case of transfusion. If the same group is not available, please, if it's an emergency, please do not delay the transfusion. Look for the most compatible next unit. If it is cross-match compatible, you give it to them. That's it. For platelets, so there is second table is for FFP and cryoprecipitate, and the third table is for RDP or the platelets. Just note that platelet doesn't have to be group specific. You can give across to any group, any patient if the same group is not available. There are a few criteria to look into when it's transfusing for neonates or for female patients. But as a rule, if it's an emergency, you can give any group platelets to any patient. Now, as a final note, this is my last slide. So you take each patient and study them and optimize your treatment for the blood or the anemia for this patient. It has 3 pillars. First is optimize erythropoiesis. Second is minimize the blood loss. And third is harness and optimize the physiological reserve of anemia. For a surgical perspective, preoperative, intraoperative, or post-operative. So if you take the first pillar, you can see that you have to detect the anemia, identify the underlying disorder, manage the disorder, and things like that preoperatively. And when you're coming to the second pillar, you have to do something to minimize the blood loss, identify the bleeding risk, how the patient can bleed during the surgery or the procedure, minimize the iatrogenic blood loss, and things like that. If it's a massive surgery, you can plan it, you can rehearse it, things like that. And the third pillar is optimize the physiological reserve of anemia. Assess and optimize the patient's reserve. Compare estimated blood loss with the patient's specific conditions, like the patient has a renal failure or something like that. And you keep a particular restrictive threshold for that patient. So you do not blindly keep on transfusing for that patient. Have specific cutoffs for that particular patient. So this is called as patient blood management. It is becoming more and more popular than the rather blindly transfusing to all the patients. So with this, I would like to conclude. I will be glad to take any of the questions that you have.
Yes, what a wonderful session as expected. So now we will take 1 or 2 questions due to time constraints. So please, you can either put in the chat box or comment on the Clarinet platform.
Okay, I have received one question: when to transfuse blood in a post-surgical patient? So, like I said in my previous slide, you have to take 2 things into consideration. One is this slide. So try to avoid transfusion for a patient as much as possible. Using these scenarios, analyze each patient and see how you can reduce the transfusion. The other one is the transfusion threshold I had shown you here. So if it's a normal patient, suppose he's a 30-year-old adult male with no comorbidities, nothing. He just came for a lipoma excision. But unfortunately, the patient is bleeding. The patient had a hemoglobin of 11 or 12, but for some reason, the patient is bleeding. You can wait up to 7 to 8 gram per deciliter to start a transfusion. Even if the patient loses from 11 to 8 grams, you can wait actually. You don't need to replace or increase your hemoglobin back to 10 or 11. You can wait till 7 or 8. You see if the bleeding is stopped, the case is over and the patient is stable. You close the surgeries, and after that, you give them oral iron. or IV iron if needed. Oral iron, the treatment might have to be continued for maybe 6 months. But without a transfusion, his hemoglobin levels will gradually increase over time.
Yeah, we have another question from Dr. Ajmal on the climate platform. So I will ask for him. Is a bystander always recommended to accompany the person when going for blood donation?
No, for blood donation, bystander is not necessary actually. Blood donation is considered as a safe procedure actually. So it is the responsibility of the medical officer at the hospital or the blood center to ensure that the donor is safe and no harm befalls the donor. And we have a thorough screening procedure to screen the donors. You check the BP, you check everything, and if the questionnaire is everything is perfect, then only you are able to donate. So there are no issues. Once in a while, there is a chance for something called as donor reaction. The most common one is vasovagal reaction or donor fainting. It is so all of these are healthy adults. They faint either because of the anxiety of the sight of blood, or there is a sudden drop in blood pressure. With just foot and elevation, you give them oral fluids like just water or refreshments, and you wait for 10 to 15 minutes. It will automatically recover. So usually, majority of the case, this donor reaction does not need medical intervention. So it's a safe procedure, and you can go alone to donate the blood. It's good if you have a friend with you, but you can donate alone, no issues. So there is, I see one question in the chat box. Can we continue transfusion in case of simple allergic transfusion reaction and investigations are unremarkable? Okay. The thing is that you can continue the transfusion in case of a simple allergic transfusion reaction. But again, we have to see in what setting you are transfusing. You have to be confident in your blood bank's capacity and your staff capacity. Many hospitals refrain from continuing transfusion because they are afraid that the patient already had some kind of reaction. Now, again, if I transfuse, if something happens, if there is some complication, it will be on my head. So they will advise against continuing the transfusion. Ideal situation is you can continue the transfusion even after a simple allergic transfusion reaction. Okay, now somebody has inquired about the career perspectives of a transfusion medicine. So the thing is that transfusion medicine is comparatively a younger field. Maybe 10, 15 years, 15 years has been since the transfusion medicine has been established as a specialty. The scenario in India is that we have around 4,000 blood banks in all over India, around 300 blood banks in Kerala itself. So majority of these blood banks or blood centers are run by MBBS doctors or pathologists. So the government started transfusion medicine as a specialty to improve the quality and to strengthen the blood transfusion services of our country. So the core is blood banking. Like in the slides you have seen that my specialty is about blood and blood products. So we have multiple sub branches which have scope in the future. Some of them include coagulation. So for example, Jubilee Mission Medical College where I studied, it has an excellent coagulation laboratory, and we manage cases of hemophilia. We can manage cases of coagulopathy at Jubilee Mission Medical College. Then there are centers with apheresis technologies. So during the COVID, there was a requirement of convalescent plasma therapy, a specific procedure called apheresis, like I said mentioned before. This apheresis can be used for therapeutic plasma exchanges. It's a procedure that requires large amount of plasma and a specific equipment, and with that remove the patient's plasma and replace healthy plasma. For example, in conditions like Guillain-Barré syndrome, if you remove the patient's plasma and replace healthy plasma, the patient will improve. So there are conditions for which therapeutic plasma exchange can be used. So there is then there is immunohematology, which is not at all developed in our state or country. It's starting. So like I said, Jubilee Mission had a very good immunohematology workup session. So we all are familiar with the ABO blood grouping system and the Arch positive negative, but there are minor blood groups systems like Kell, Kidd, Duffy. All these blood groups are mix and matched on our blood's RBC surface. Don't know it. The most important one is ABO and RH. So we are sticking to that one. In developed countries like UK, they will do the ABO RH grouping. Then they will go for extended phenotype, something called as RH.
Hello.
And giving it to the patient. But our financial situation and our healthcare setup is not so strong that we are able to do it for all the patients. So sometimes we'll get cross-match incompatible, or we see that patients
Sorry for the inconvenience. It seems like due to some poor network, Sarah has left the meeting. So please connect it with us. Stay connected with us. The speaker doctor will join us soon.
I think my internet connection was weak and I left the meeting. So are you able to hear me now?
Yes, sir. However, sir, the PPT is not visible on the screen. So can you please reshare?
Yes. Okay. No, I'm not actually sharing that much from the PPT, so it's over. So regarding the scope of transfusion medicine, it's a growing specialty, and you need time to develop a specialty because all of our settings require a lot of equipments and reagents to do our test and processing. For example, a good quality, one of the best company blood bag centrifuges, which is required to prepare a PRBC plated cost around 30 to 40 lakhs. So one centrifuge, it might cost around that much. So for all the equipments in the blood center, it's very costly. So it's very difficult to develop and cost intensive to develop a blood center itself. For all these extra procedures like immunohematology, antigen identifying, antibody identifying, you need to have a lot of facility. Then few of them has diverged into genetic testing. So some of my seniors and colleagues are in the genetic aspect of transfusion medicine. Then there is something recently came up as CAR T cell therapy, chimeric antigen receptor therapy. This it's coming as a treatment for mainly for India. Has got one company has already got the license and they have started in Amurda and MCC Talasheri. So for that, if you harvest the patient's T cells, for suppose the patient has myeloma, and we using the apheresis technique, we transfusion medicine harvest the T cells of the patient, and we train that T cells to identify the cancer antigens, and it will take about 7 to 14 days. You train the T cells and return it to the patient to fight the malignancy. So there are upcoming advances in transfusion medicine, but the thing is that the specialty is still young. There is a lot of scope, but we'll have to wait and see how the infrastructure and everything develops. Even from the government perspective, government is trying to bring up a lot of changes. There are a lot of blood banks in India, but we are not able to bring up all the 4,000 blood banks at the same time in India. So the government is trying different strategies to improve the quality of blood and transfusion. Now, one of the queries is scope of transfusion medicine in foreign countries. the thing is that the medical, as you all know, the medical education system in India is different from other countries. So they do not follow the you pass the entrance exam, you go to MBBS, then again on an entrance exam, you get an MD. It's a bit different from there. So in many of the European countries, especially, most of you will be trying to go to Europe and US, so UK. So there, it's not a per se MD course. MD pathologist is doing a fellowship, or they are choosing a side specialty as a transfusion medicine. So they do not have an MD transfusion medicine. They have other doctors who specialize in other field who diverges into the field of transfusion medicine. In foreign countries, the transfusion medicine includes, like I said, this CAR T cell therapy, apheresis medicines, and the therapeutic plasma exchange procedures like that. The difference between India and European and US is that our health system is entirely different. So in Europe and UK, the government takes majority of the health systems, and they have well-established hospitals, all the facilities. At the same time, in India, majority of the healthcare is through private hospitals, which are small centers. And even if it's a government centers, there will be small centers with the bare minimum equipment and the facilities. So there is a long way to go for transfusion medicine in India.
Okay, so I think we'll conclude with this last question from Dr. Nanda. So she's asking, is bone marrow transplantation a part of transfusion medicine? Can a transfusion medicine specialist do BMT?
Okay, so in my previous center at MBR Cancer Center, we used to do bone marrow transplantation. So the transplant unit is under hematology or medical oncology. The role of transfusion
I think there's a connection problem again.
And on the 5th day, we'll post the patient, and if there is equipment. Are you able to hear me now? Hello?
Yes, audible now, sir. Please go on.
So on the 5th day of after giving granulocyte colony stimulating factor, we using a procedure called apheresis. It takes about 4 to 5 hours. We harvest the stem cells, and we after the harvesting, the stem cells will be in a blood bank. So we take it to the blood bank. Either we can keep it like that for 72 hours, or we can procedure called cryopreservation, where we freeze the stem cells for a long period of time. Like we can keep it up to 10 years. So up to that part, and when the patient requires the stem cell, we take it to the transplant unit and we give it to the patient. And the other thing I would like to mention is that MBBS, MD, and transfusion medicine, as per now, MD transfusion medicine is not a feeder course for hematology, DM hematology, but we are trying to get to be a feeder course for DM hematology. We have applied for it. There are few fellowship courses in few of the centers in India. Like there is one available in Malabar Cancer Center, Talasheri. There is a fellowship called Hemato-oncology and Bone Marrow Transplantation. It's a 1-year fellowship course. And in that course, the MD transfusion medicine is a feeder course. So you can go to MCC, be trained in hematological malignancies and stem cell transplantation for 1 year, and you can practice.
Okay, so with that, we are coming to the end of this session. I would like to welcome Dr. Azharuddin from GPA to give a thanks note and also to conclude this session.
Hello.
Yes, you are audible, Azharuddin. Please go
on. Thank you, Dr. Ansar, for the introduction. I'm coming straight to my duty. I would like to thank Dr. Arun Vijay for leading this wonderful session on transfusion medicine and for providing us with insights on the topic from both the perspective, from the clinician's perspective, as well as for discussing, for sharing your insights on transfusion medicine as a career. You have been very honest with your insights. You have put the limitations as well as scope for the subjects, and Once again, I would like to thank Dr. Arun on my personal behalf, as well as from General Practitioners Association's behalf. And I hope Dr. Arun will be associating with GPA with more discussions in future. And I would also like to thank GPA Academic Wing for conducting this session, especially Dr. Hamid Ali and Dr. Ansa and all other members. You are doing a wonderful job with all the limited time you have. And I would also like to thank ClearNet for providing platform and opportunity to conduct this sessions for the betterment of young doctors. Once again, I would like to thank all the participants for the participation. It's the participation is the success of key in success of any program. So I would like to thank everyone, and I think we can conclude the session right now.
So thank you, GPA, and thank you everyone for this opportunity. You can contact me through my personal mail ID, and you can visit my website, which I run. Or if you have any doubts regarding transfusion medicine, you can contact me directly, or you can contact through the GPA. And the purpose of transfusion medicine is to educate everyone, including the common man and the doctors, regarding the blood and improve the blood transfusion system of our country as a whole. So I am willing, and our organizations are willing to collaborate with any of you. And if you have any doubts and you need further sessions, we are willing to help. Thank you.
Thank you so much, sir. Thank you so very much thank you so much to all of you. So now, with all your permission, I'm closing the session here for today and looking forward to hosting you again. So, and good night to everyone. Bye.